Good day, everyone. My name is Samuel Kaba Akoriye. I am the Director of Clinical Services of the Ghana Health Service, a consultant neurosurgeon, and a public health physician. First of all, please do accept my apologies for not being able to be with you to share these memorable moments. Due to situation beyond my control, I've not been able to back on this trick, but I hope and look forward to future opportunities. To Dr. Gupta, my apologies. Ghana, my country, is situated in West Africa with a population of 31 million citizens. I will be talking today on neurotrauma, the challenges we face, how we do it, and our vision. But let me emphasize on the point that I don't intend to exclusively talk on neurotrauma, but putting together my experience as a director of clinical services, as a public health physician, and as a practicing consultant neurosurgeon. Putting all that together to talk of health system thinking and intersectoral collaboration on how we will get our patients in better conditions. So the goal is to help all of us to rethink on how to increase access to quality pre-hospital, hospital, and post-hospitalization emergency services, which will help improve patients with neurotrauma. Road traffic accidents and other intentional or unintentional injuries, including neurotrauma, have become a silent killer in Ghana in the last years, gradually replacing the old known infectious diseases, TB, malaria, HIV, and AIDS. So it is worldwide that WHO has projected that by 2030, low-income countries will be experiencing cardiovascular diseases, and road traffic accidents together with intentional or unintentional injuries will be replacing the regular infectious diseases. The cause of this increase is due to, one, lack of attention to prevention, and two, lack of emergency care. This is a building in my country that collapsed some time back, and this is after. And we had a lot of trauma cases, especially neurotrauma. Just before the advent of COVID-19, within the month of January to February 2019, we experienced 2,126 crashes with fatalities of 411, according to the National Road Safety Commission. And most of these injuries had neurotrauma component. So, in Ghana, motor vehicle accidents constitute 50% of the injuries that we see, falls 20%, sports, violence, and others take the rest of the percentage. Now, worldwide, WHO has established as a fact that approximately 1.3 million people die each year as a result of road traffic accidents. Road traffic crashes cost most countries 3% of their GDP, and road traffic injuries are the leading cause of death for children and young adults aged 5 to 29 years old. So I usually say unquantifiable is the burden and financial cost to a family with an accident patient. Because one, they have to adjust work cycle to accommodate hospital visits, remodeling of the house if the patient is disabled, loss of work and productivity, and if the patient happens to be the breadwinner of the family, then it's even more catastrophic, and all the psychological effect that it comes with. Now, it's been projected that megacities in Africa will experience a rise in population by the year 2025. We are already feeling it. And unfortunately, the means of transportation in all these megacities is by road. So we expect to have more increase in road traffic accidents. So how do we deal with this situation? We need to apply health system thinking with intersectoral collaboration. We will have to incorporate proven solutions into resource constrained environments, and strengthen local health care systems and support local solutions. Change the way leaders think about the health issues and engage the private sector. As they say, prevention is better than cure. So we in Ghana have started talking to the Ministry of Road and Highways in construction of good roads with signage, street lights, etc. With the Ghana Police Service, the Motor Traffic and Transport Department to enforce rules and regulations. The Ghana Ports and Harbors to reduce tax on importation of brand new vehicles as to importation of used old vehicles and used spare parts, because we all know used vehicles, the consequences. This is a homegrown initiative to build health posts along highways, so when people have an sustained road traffic accident, they can easily get first aid before they get to definite care. So medically, we attempt, or we try to look at this from the style of life perspective, to build a health infrastructure around early detection, early reporting, early response, on-scene care, care in transit, and transfer to definite care. These will also include rehabilitation, psychotherapy, occupational therapy, assistive devices, etc. This approach has 3 steps. 1 is community level preparedness, 2, pre-hospital engagement, and 3, hospital emergency teams. We building a referral system that will facilitate the transfer of patients. And infrastructure-wise, we're looking at permanent hospitals, ambulance services, field or mobile clinics, and mobile hospitals. And to engage the whole community, the government, the public, and the business or private sector. Now, neurosurgeons are part of a team and depend on other key players or specialties to appropriately manage neurotrauma patients. So these are some of the challenges we face in Ghana: human resource, logistics, equipment, transportation, community engagement, infrastructure, and volunteers. Human resource-wise, Ghana currently has 22 neurosurgeons, few intensive care specialists, radiologists and radiographers are few, emergency medicine specialists very few, anesthesiologists and physiotherapists are also very few. Equipment and logistics, few centers with the appropriate HR and needed equipment and logistics to perform neurosurgical procedures. The 22 neurosurgeons I've spoken of are located in just 4 regions out of the 16 regions in the country. 4 regions also have the possibilities of manufacturing assistive devices. Now, with our infrastructure, although most regional hospitals have the necessary conditions for neurosurgeons to perform their duties, most lack the required equipment and complement of other specialties, e.g. CT scanners, MRI, ICU, etc. But we're also looking at the possibility of developing emergency medical teams where we can deploy field clinics whenever there is a disaster. Bystanders are usually very important and the first people to be at the accident scene. So we are engaging the communities to train them. However, this gradually is becoming a little difficult due to the scanty resources. This is everyday occurrence where we have a lot of accidents, and as we can see, the first people to arrive at the scene are the bystanders, and they need to be well trained to handle these kind of cases before they come to us as neurosurgeons. Transportation-wise, we're looking at our National Ambulance Service and how best we can achieve the platinum 10 minutes and the golden 1 hour before so that patients get to the hospital in good conditions. And these are examples of our National Ambulance Service. We've also modified motor vehicles, motorcycles to suit the national needs of transporting people as quick as possible to the hospitals. Air ambulance is the fastest means of evacuating people to the hospital. However, currently in Ghana, this is under the control of the military. However, plans are being made to work hard for this to become a regular use. And its cost is not so affordable to every person. We have placed boats on our island communities to also assist with the transfer of patients. And in 2019, we established drones to facilitate the transport of vaccines and blood products to hard-to-reach areas. Now I will talk about neurotrauma briefly from the neurosurgical perspective. In one of the hospitals that I do work time to time, which is the Rich Hospital. Unofficially, as a unit in Rich Hospital, from October 2020 to January 2021, we realized that 35% of the cases that we received were neurotrauma. Males were many, by 70%, and head injuries constituted 65%. I will not spend my time to talk about classification of traumatic brain injury, as we all know. Neither would I want to talk about the Glasgow Coma Scale, which we all use in evaluating these cases. Management usually is clinical assessment, medical, and surgical. Principles of management: we apply our ATLS protocol, adequate imaging, and appropriate treatment with all the consequences of mortality. Initial management, as we all know, airway, and our ICP protocol, which I'll make emphasis on later. The appropriate medical management, use of fluids, analgesia, antibiotics, anti-seizures are all being used in our center as well. ICP management protocols, positioning of the patient, and the rest are all being instituted in our facility. I bring to you a case of head injury with a depressed skull fracture. And just to illustrate that not all the time patients are able to afford the purchase of cranial fix and other neurosurgical devices. So this is how we do it, with sutures whenever that needs arises. Neuromonitoring of ICP. The key target to monitor and treat ICP is to optimize the cerebral perfusion pressure. And in our facility, most of the time we place the catheter inside the ventricle. Although we do know, or we sometimes have ever used the intraparenchymal, subdural, epidural, and subarachnoid space. However, we do also recognize that infection, hemorrhagic complications, and mechanical destruction of the catheter setup are some of the complications that we face. Fortunately, the use of neuronavigation and ultrasound has been very helpful in accurate catheter placement without complications. As I said, some of the challenges we do have is that most neurosurgical procedures are not covered by our National Health Insurance Scheme. So patients have to purchase all the devices. ICU and PICU stay very expensive for patients. So some of the other methods used in our department with less cost to patient is sonographic measurement of the optic nerve sheath diameter. Others include transcranial Doppler. However, with infrared, pupillometry, and telemetric ICP measurement, we've not done that, but can be done. Nothing will get done if we wait to do something so perfect without a mistake. So our vision is to train and develop the human resource mix, continue to improve the infrastructure, equipment, and logistics, advocate for National Health Insurance to absorb all aspects of neurosurgery and other specialties to alleviate patients from bills, advocate on prevention and health promotion to reduce RTA, and advocate for improvement in pre-hospital services. We also have the vision to strengthen intersectorial collaboration, improve referral system, improve community engagement, strengthen rehabilitation units, improve manufacturing of assistive devices, and advocate for necessary ultramodern equipment for practice of neurosurgery, and develop Ghana as a hub for medical tourism for the sub-region and beyond. In conclusion, little money, many responsibilities. We are all potential victims or patients. So please, let's work together to save lives wherever they find themselves. Special acknowledgement, the organizers of the conference, especially Prof. Deepak, for extending this generous invitation to me. Please, let's find time to visit Ghana, which you will always be welcome. And thank you, everybody. Thank you for listening. Thank you. God bless us.